Hello, it is a true honor to introduce to you again Dr. ROSHNI KULKARNI, our keynote speaker. She is currently Professor Emerita, Pediatrics and Human Development, Michigan State University, and former Director of Center for Bleeding and Clotting Disorders and Pediatric Hematology Oncology, and former Director, Division of Blood Disorders, Center for Disease Control and Prevention, Atlanta, Georgia. She graduated from Osmania Medical College, Hyderabad, India, and completed her residency and fellowship at the Children's Hospital of Michigan, Detroit, Michigan. She is a founding member of the Foundation for Women and Girls with Blood Disorders, our sister program to CODEROUGE in the United States. Dr. ROSHNI KULKARNI has been instrumental in the advancement of care for women and bleeding disorders. She has devoted her entire career to hemophilia and inherited bleeding disorders and is a role model and inspiration to us all. She is a devoted caregiver and approaches all that she does with passion and warmth. Her multiple awards, such as Fairy Godmother to Women with Hemophilia, Women's Leaders in Hematology, the National Hemophilia Foundation Physician of the Year, Michigan State University Distinguished Faculty, in addition to her various contributions in the form of research, publications, invited presentations, contributions to patient outreach programs, including Telemedicine, and her involvement in many important organizations related to women and bleeding disorders, both nationally and internationally, is not only a testament to her dedication to this field, but also to the high esteem in which she is regarded by her patients, colleagues, and peers. I would say that we all have a lot to learn from her. It is truly a great honor and privilege to have her speak to us today. I can think of no better person and speaker to deliver the keynote address of CODEROUGE 2021. Thank you, Dr. KULKARNI.
Well, thank you so much. I am indeed honored, and it's a pleasure. Thank you to Rochelle and to Wendy for inviting me to be the keynote speaker for a kind of a very different topic: transcultural experiences in issues in the care of women and girls with bleeding disorders. So when Rochelle asked me to speak on this, I'm like, oh, I never thought about it coming from a different culture. But I thought this was a challenge, and I would bring some aspects of my personal experiences and kind of talk about it, because we are living in this cultural conundrum, and with all the refugees and migrants and things like that. So I think I will start out with saying, what is transcultural issues? How do they affect women and girls with bleeding disorder? And I think there are three areas which we know it will affect women and girls. One is a menstrual issue, pregnancy, delivery, and postpartum issue. And then there is this other whole group, body modification, and I'll address that a little bit. And how can we deliver care to all these different culture groups who may not live close by to us, using telemedicine and digital technologies to overcome the barriers of culture, distance, language. So what does one mean by transcultural issue? So it's just being sensitive to the cultural differences and show respect for people's belief and related healthcare practice, and provide culturally competent care, because we all, come across these women as colleagues, as patients, as children. So that's very important for us to learn. So according to the American Medical Association, cultural competence is, the knowledge of interpersonal skill, and basically it involves awareness and acceptance of cultural differences so that you can give appropriate care to these patients. So what does that have to do with women and girls with bleeding disorders? Well, all over the world, women and girls with bleeding disorders are disproportionately affected. And the most common condition, and you all know this, is heavy menstrual bleeding, seen in almost 90% of women and girls with underlying bleeding disorder. And then they experience other conditions as postpartum hemorrhages, miscarriages, et cetera, And you can see that cultural practices may impact women and girls with bleeding disorder more than those without. I mean, cultural practices affect almost all women and girls, but when they have an underlying bleeding disorder, they have a double jeopardy. So inherited bleeding disorder are lifelong, and you are aware of this. I'm not going to go into this, starting right from adolescence to the menopause area. So at each stage of life, they can be affected. This was a paper, interesting paper from Iran by Dr. Karimi and all. And you know that Iran has high rates of Glanzmann's thrombasthenia, factor 13 deficiency, von Willebrand's disease. And so they reported over on 1,500 women. And what they found was they have difficulty getting married. They have difficulty in keeping their disorders secret. And it really causes a lot of emotional distress. And they don't talk. They are silent. So these are really the silent majority. And even in a clinical setting, they don't feel comfortable. And clearly, a lot of them prefer, having gender-specific healthcare providers. And so one has to be aware of that. And currently, we know that our clinical practice is globalized. Even in USA and Canada, we have the Amish, the Native Americans, and migrants from just about every other country. And I looked at this map of Canada with the native population spread all over. So you see, you have to know their culture. You must know what they go through and must talk the same language, in terms of understanding women and girls with bleeding disorders. So be familiar with their cultural, social views so you can provide good care. So in many cultures, talking about menses is really a taboo. I remember seeing a girl and I wanted to say, so how are your menstrual periods? She looked at me, she said, what? What's that? So I said, oh, menstrual period, what do you call it? The days when you bleed. Oh, my leak week. So I'm like, yeah, leak week, that's when you leak. So then I found out, I was at a meeting with the World Federation with people from different countries. And I said, what do you call menstrual period? What are the nicknames? Chums, Crimson Wave, Moontime, Ant Flow, I think it's in England, Leak Week, Code Red, which is your name of your organization. And basically, the diagnosis in all these girls will be challenging. And you need to know that a lot of these people may use traditional remedies such as cupping. I've had cupping. It's a Chinese thing where you put a cup and stick a little, and have a little smoke, and it kind of creates a suction. And when you leave that, it creates a bruise. Now think of a girl or a woman with a bleeding disorder. When you do this cupping, you'll have this rounded bruises all over the place. In addition, a lot of countries use counter irritants such as methyl salicylate and capsaicin, and that can enhance the bleeding. And then, of course, I'll talk about the body art and body modifications, piercing, things like that, which is common in these girls. So here is a picture sent by Susie Cooper from Australia. This is the Shark Week. And the reason it is called a Shark Week is if you pass a little amount of blood and go into the water, boy, oh boy, those sharks will come after you. And these are the undies you need for your week-long stint in purgatory. I love that. So be aware of this. So how did my journey begin? Well, when I was 6 years old, you can see this little woman sitting in a bed. My mother, who was with me in the village, suddenly I was asked not to touch her. I couldn't go near her. I couldn't touch her. She was in isolation. She was given her food, and I was a 6-year-old child who was devastated because, I wanted my mom. And then later on, I learned this is a normal practice. Even today, to some extent, it prevents the woman from doing housework and all that. But it is pretty traumatic, not only for the person, but also for the children, I think, who don't understand that this is a cultural thing. As I grew older, I used to attend this half sari function. What that means is that if you go look at the picture of the little girl and the big girl, the little girl is wearing a blouse on the top and a skirt at the bottom. But the girl who's sitting down, in addition, is wearing what I call a modesty rag to cover her breast. So this is a celebration of menarche. And what it is telling the world is my daughter is mature and ready for marriage. So this is a celebratory thing, even to this day, half sari function, and people have invitations for that. So one has to know, you can ask, have you had your half sari function? And then you know that the person has had menstrual periods. And what is very interesting is even in countries like Japan, because of the culture, women don't speak about their periods or bring to attention to the physician about what they're undergoing. So you can see on picture A, this woman was sobbing. I was at this meeting, on the first meeting by Dr. Nishida on women and girls, and she bled tremendously after following the birth of her baby with hemophilia, and she couldn't remember the birth. And she was sobbing, saying that I didn't know what was happening to me. And the other two women decided to forego marriage after seeing what their brothers went through. And I asked them, when you went to visit your doctor, did you talk about what you went through? They said, no, we did not want to divert attention from our sons or our brothers. So these women sacrificed their own history. So the message here was for physicians to ask for these women's history to see, how are you doing? What are you bleeding? This one reminds me of my aunt, my dad's sister, who bled to death in a village following birth of her child. She was surrounded by women in a small village, no medical doctor. We don't know what happened to the child. And I still remember her, just a wonderful, wonderful person, but we lost her to postpartum hemorrhage. So there is a lot of mythology and culture regarding menstrual period. It's derived from this Greek word, mene, means moon. And, if you look at it, shows the power of women and their uterus and their menstrual period. They can influence cosmic rhythms and influence elements of nature. And the universe may descend into chaos if women were not monitored. So they're sacred and powerful. They can destroy enemies. They can get rid of all the insects and everything in a field. And menstrual blood is dangerous to men's power. I think that's the bottom line. So there are a lot of myths about menstruation. And so is it a gift from God? Is it a punishment for sin? Sacred? Menstrual taboo? And is it a sign of impurity and cleanliness? So this poor uterus is at the center of culture, mythology, religion, and politics. And now you can imagine in Texas, oh my God, they will not let women, even think about miscarriage and all this and report to the police. I mean, absolutely ridiculous thing, because I think they're afraid of the uterus. So a lot of religions, every religion almost, has something to say about menstruation. We never talk about any other organ in the body as much as the poor uterus. So you can see in Judaism, it's called nida, you cannot touch. Christianity has no specific rituals. Islam, they're excused from prayer. Hinduism, oh my God, there are a lot of myths about menstruation. And in many, many countries, menstruating women are considered impure. How does that impact, their care? Well, they don't talk about it. If you don't talk about it, it doesn't exist. And that's the problem. So you have to kind of pull this history out of these women. And very interestingly, in India, there is a bleeding goddess. So see, menstruation is actually sacred. So this goddess is called Kamakaya Devi, and she menstruates. You can see this picture and the temple behind it, and this whole womb of vagina and the mythical womb are installed in the sanctum of the temple. You can see the vulva and the vagina in the inner sanctum of the temple, which is prayed to. And during the month of June, this woman or this goddess is covered with vermilion, which is like blood. And the temple is closed for 3 consecutive days. And that's how in India, a lot of time when you ask them about menstruation, they say, I have had my 3 days. So that's how my mom used to refer to it, like, oh, have you had your 3 days? At the same time, there was another temple where menstruating women were banned from entering a holy shrine or a place, and there was protest, and the Supreme Court said it was a violation of the Constitution. So the battle goes on. And in Nepal, you have these little chowpadis, menstrual huts, where women are isolated. These chowpadis are there not only in Nepal, but also in Ethiopia, in West Africa, in Australian Aborigines. And you can see the bottom one is photograph is from Africa. And the problem is these women are isolated. They succumb to cold, hunger. They can get raped. They can have domestic violence. And there have been a lot of deaths reported. There have been about 14 deaths reported from dehydration. Just imagine if you're a woman with a bleeding disorder, you can bleed to death. And there have been snake bites, in these menstrual huts. So be aware of this. So when I met these Nepalese doctors, they said this practice is banned, but people in the villages still practice it. So banning by the government doesn't necessarily mean that it can happen. So menstruation can affect all aspects of a girl's life or a woman's life. Education is the most important thing. A lot of them miss going to school because school don't have toilets or facility when they are menstruating. And there was a very nice article on BBC about using menstrual cups so that these girls could stay longer in the school. Many of these girls don't stand up to answer questions because they are afraid of being bullied for bleeding through and through. So it affects the economics because they don't join the workforce, they don't pass school, and of course the health and dignity. And so there are a lot of issues, majority of it are restrictions and taboos, whether it is religious restriction, domestic restriction, like what my mother went through, isolation, etc., and shaming and stigma. Of course, period poverty, and I'm so glad many countries are addressing this. It is shameful. It's like not providing you toilet paper when you go to toilet. Well, this is a physiologic thing, and I think sanitary products or menstrual hygiene product should be a part and parcel of what is provided to these girls. So what about pregnancy? Well, this is very common. When I was in school, a bunch of my friends got married as soon as they attained menarche. And these were young. And when I was a resident, I did OBGYN for like 2 years. I would see these girls who would come with torn external genitalia, because in some of the religions, it's a requirement that the marriage be consummated the first day. So you have to look at the genital area in girls who come with heavy bleeding to make sure there is, episiotomy or torn vulva, vagina because of forced penetration. And, a lot of these, and you've all heard about the woman trials, I'm not going to go into this. It's a big killer. And including my aunt who died, bleeding is the leading cause. And there are a lot of rituals, like burying the placenta, and support for the mother is usually by females. And then diet. Some of these diets, like garlic and this and that can influence bleeding. And in Pakistan, heavy menstrual bleeding or heavy postpartum bleeding is considered healthy. So they may not think that postpartum hemorrhage is really a problem. They may think, well, that's pretty normal. And people wash this childbirth product and bury it in whole. So you may not get an idea about postpartum bleeding and their rituals. What about body art and body modification? It's a common practice. Tattoo, I talked about cupping, I talked about tattoo that is introducing pigment in the dermis. And body piercing, I have a bunch of patients who do body piercing, and I'm like, oh my God, you may bleed with this thing. And Kate Cairo saw that a lot of women underwent that, and that was considered a sad thing is if girls were told not to have this piercing. So if they are considering piercing, you might wish to give them, some prophylaxis so they don't believe that, or they don't bleed during the form of piercing. And then what about female genital mutilation? That's probably the extreme form of body modification, and it's removal of the external genitalia, the clitoris, and it's done with a razor blade. And amazing, because Canada and USA both have populations, there's this particular sect called Dawoodi Bohra Muslim. And recently there was a case in Detroit where the doctor, charges were brought against the doctor. The children were transferred from Minneapolis to Detroit to undergo this ritual. This is performed at age about 5 years or so. So many of these children don't remember having gone through. And so OBGYNs or people should look at, their genital parts to see if they have undergone clitorectomy. And I was surprised in Canada, 80% Canadian Bohra women, there's a very nice video about it, have undergone female genital mutilation. So you need to know their sect and all that. And this mutilation causes severe bleeding and painful menstrual period, and a lot of complications. And it's just not only in Africa, it's in Indonesia, it's in many, many countries, in Saudi Arabia or the Arabic countries. So be aware that this practice goes on, and clearly if you're a girl or a woman with a bleeding disorder, it may accentuate it. So what can we do to overcome these barriers? How can we learn about other culture? Can telemedicine bring equity and digital technology bring advocacy? So let's look into that a little bit. Social media, global platforms are enabling women to share information. So if you go on Facebook or Twitter or WhatsApp, oh my God, there are so many girls talking about periods. What we as physicians couldn't do, social media is doing it. And it is encouraging activism and menstruation stigma. Happy to bleed, periods are not an insult. And Trump's remark on Fox News, remember he said blood coming out of Meghan, who was a reporter out of anywhere. It got such a terrible thing in social media. And they're encouraging advocacy, especially period party and menstrual hygiene party. So you have to use the social media. I think if you want to reach your patient, please use Twitter, WhatsApp, social media to your advantage to promote education. And the telehealth, on the other hand, overcomes other barriers, not only for patients, it's time and cost saving, but for remote healthcare providers, as we said, it decreases professional personal isolation. So what I do when I do telemedicine is I show these sites, like for example, sisterhood site, to say, how can you track your periods? So I can show that to them on my thing saying, hey, show me your iPhone or show me your smartphone. Let me take you to that media and show you how to use that. So, it really helps the patient, helps the healthcare provider, and of course, societal help. It decreases cost of care and visits to the emergency room, etc. So I'm just going to give you a very brief 101 on telemedicine. So you can see telemedicine is the billable service, whereas telehealth is the overall service, which includes education, administration, remote monitoring, etc., etc. So it's like the big issue. So there are two types of telemedicine, synchronous and asynchronous, and I'll mention about that in a few minutes. And remote monitoring, which a lot of us are doing now, monitoring, you can monitor periods, you can monitor whatever it is, and using your mobile devices and internet to obtain health information. So just to show you, asynchronous store or forward is have camera, take a picture, and transmit it. And we use it. So for example, the bottom picture shows a child with hemophilia who crushed his hand in a car door. And what did they do? They sent me a picture. Should I go to the emergency room? Of course you should go to take factor first. Go to the emergency room, got an x-ray, and he had a bone fracture. There is a cell scope available that can detect sickle cell disease. And of course, you have your radiology images that can be transmitted. Synchronous real-time medicine, and we have done like comprehensive care medicine. So I can see you, either the doctor can be at the remote area or a primary care physician, and you can do both. And we have used things like telestethoscope, teleautoscope, and I have a picture of the otoscope picture. It's actually a better thing than what I can see with my own eyes. The only problem is it requires large bandwidth. So what is a bandwidth? Think of a bandwidth as a highway. The more number of lanes you have in highway, the more cars can go. That means more images can grow. A small bandwidth, which is unfortunately the issue in a lot of remote areas, you can only have 1 or 2 cars. And it's expensive, and we need governmental help in order to get health equity. So you have to overcome distance, overcome cost, overcome cultural barriers. You can have an interpreter as a part of your team. And you can, it's multilingual, digital technologies available in all kinds of languages, French, Spanish, English. And you can, collect this information from the patients. And here is, pregnant person. You can deliver all kinds of at-home monitoring of weight, fetal heart rate, blood sugar, lactation support. So this is all available for your patients via these telehealth services. And distance and location. So we have been doing it since, as I said, 1991, for areas as far as 700 or 800 kilometers. And we don't have to drive there. They don't have to come down. So it is really cost saving. And as I mentioned before, you can do telemedicine internationally. And the only problem is the time zone. You have to align it. And one can do it with, different countries. You can see Dr. Johnny Malangu from Africa. We did a televisit with him. And we have done it with England and India. So it is possible to do teletwinning at any point in time. And you can actually do comprehensive in-person visit and alternate it with telemedicine visit. So do kind of a hybrid thing. And that's what we do too. We sometimes in our clinic, we see a patient and we have given patient choices. Do you want to be seen in person or do you want to come by, be seen by a virtual visit? And many patients opt virtual visit because they're afraid of catching COVID in the hospital. And others, meanwhile, prefer a telehealth visit. And so why do we need virtual visits during a pandemic? So this is a guy who had a turkey attacked him while he was visiting his mother's grave. And so what does he do? He sends us a picture. He's got severe hemophilia. And so I said, oh my God, you need a tetanus shot and all this. And he did not want to come in. And, it really, we could provide him the care. We did not need any protective equipment, PPE. So it reduces the cost of PPE, reduces the cost of exposure. And then 2 days later, he sends another picture saying that it is healing, it's doing very well. So we were able to follow him. And this is on a cell phone. So you can see, it has got great potential. And here is a girl who I saw for heavy menstrual bleeding and made her do the Beighton score. And you can see, she said, no problem. She jumped down and put her leg behind her back, and you can see her thumb position. You can diagnose this pretty easily. And along with the the primary care. Here's another lady who could not straighten her leg. She has hemophilia B, and I'm sorry, it should be factor 8 deficient. I'm sorry, factor 9 deficiency. Factor 7 deficiencies in the bottom picture, where she would go ballet dancing and have hematomas on her toes. So all these were diagnosed by telemedicine. And this woman underwent knee surgery at her hometown, which was like 100 miles from us, and did very well. And so during the pandemic, we also did pregnancy counseling for hemophilia carriers. And you can see the adult hematologist. We had the genetic counselor, myself, and the nurse in different rooms doing pregnancy counseling for hemophilia carriers. So there are still challenges. So there is a digital divide, the have and the have-not. There is, even though telemedicine can give health equity, there is still, digital illiteracy. So you have to tell patients how to use this and what. And digital refugees, especially the migrant population. So there are all these new challenges that we are facing, and you have to involve the government to help you. So much so the CDC and the FDA are now looking into appropriating funds to have bandwidth, hotspots, so that even children in remote areas can attend, school by televisit. So that is a current problem we are facing. I'm not saying it is perfect, but we definitely are facing and trying to address this issue. So a combination of mobile health technology has been used for virtual hospitals. So what do you do for remote patients? So all these COVID patients are put up in sometimes in their home with monitoring by nurses and staff, and you can get telemedicine counseling. And if a person has a smartphone, they can have all their apps. They can measure their blood pressure, their pulse, et cetera, et cetera. It's called the Internet of Things, IoT. And it can go to a cloud, be transmitted to their physician, to their healthcare provider, and the risk assessed. And what about drone technology? We said, how do we get products to that? And that was called drone to door delivery of blood, medicine. And we actually thought about it for delivering factor concentrate, to remote areas. It is possible. I mean, believe me, in the future, this is going to come. Instead of Amazon taking all their trucks and polluting the atmosphere, we'll have these drones, doing this. And in China, it is used for crowd control, for monitoring mask wearing. I like that. And wearing or delivering protective equipment. In Australia, monitors temperature, respiratory symptoms. In Ireland, for insulin delivery, and remote kits and remote monitoring. And I think one of the things I see its use is probably lab. Lab access is a huge issue in remote area. Perhaps in the future, you can see drone technology taking lab samples and delivering it on time to the different laboratories. And when we collect all this information on all these people in the remote area and in your area, you can apply artificial intelligence to determine, the risk categories. And it has already been used in all these situations. Image analysis is probably the most common place where it is used. Virtual nursing assistant, workflow, clinical judgment, etc. And so how do we prepare for it? We really have to know that digital technology and teletechnology and telemedicine is here to stay. So we better get acquainted with it, aware of it, and know about it and use it. And as the WHO director, Tedros Ghebreyesus said, telemedicine or telehealth is an equalizer, and harnessing the power of digital technologies is essential for achieving universal health coverage. So that's my talk. Thank you very much. And these are my acknowledgements.
Thank you very much, Dr. Kulkarni. And I have to tell you that not only was that an outstanding presentation, but it was actually quite humbling and as well eye-opening. And it shows to what point that you're really an innovator, a leader, and a visionary. And I think that your expertise has added greatly to the context of the mission, the common mission that we have in Canada, the United States, and all over the world, is to offer better care to women with bleeding disorders. And certainly the themes that you've mentioned will help us step by step get there. And mostly by getting us all on the same page and trying to really understand the obstacles with which we're faced and the reality in which we're faced, and to try to overcome some of those obstacles together. So thank you for the content of that. So far, I don't have any particular questions from the audience yet, but I do have one. And speaking as a hematologist who sees both adults and pediatrics, I have been faced myself with difficult discussions with patients from other cultures. And this notion of hiding and not saying is very prominent among those patients, like you mentioned. And you know, aside from being a human and trying to gain their trust, it becomes very challenging because they don't want to talk. And I remember in particular a young adolescent patient who came to me with her mother, and we were talking about ways to get her periods to a level that was less important. And there was more silence in that room than there was dialogue. And not to mention when I mentioned that the birth control pill was going to be the first option most likely, and then went quickly to tranexamic acid because I saw that it was not met with a great acceptance. But there was so much silence in the room. And my question to you is, how do we as caregivers breach that cultural divide on site in our clinics in real time?
So I think you bring forward a very real issue, and I face it all the time. In fact, the problem I face is sometimes these girls come with their fathers and not their mothers. And they are zipped. They will not talk about their period. So I have to actually send the father out of the room saying that I need to talk to your doctor and about girly thing. And if there is complete silence, I usually ask them very non-threatening questions. Tell me about yourself, and where are you from, and what do you do, and do you do this, and do you do that? So kind of very slowly bring in the issue. You're absolutely right about contraception. It is not an acceptable practice, and we call it hormonal therapy and not contraception. And they all think the minute you put them on the pill, they're going to run and have sex and with 200 men and whatnot. And that is not the case. So, right. And I tell them there are other options. This is one of them. And I tell them it's not for sex. And so I have to first understand their culture. So usually, I've taken care of African women and all that, and they have a totally different culture. I find it very difficult even to talk to the Amish women. So the last Amish clinic we had a couple months ago, there was this woman who was pregnant. And I found out that they use midwives in their community. So right now I'm trying to see, can I reach these populations through midwives who, for some reason, these populations trust, all right? Or can I talk to them about their culture and then gently approach the subject saying that, and I think in many cases, gender makes a difference. I mean, you and I are the female gender. So I usually tell them, hey, I menstruated most of my life. So I understand where you're coming from. And so that kind of sometimes breaks the barrier, but sometimes it is very, very difficult, to overcome the silence. The other thing I have faced is, like, I have a boy with factor 7 deficiency, and I've asked the father, because there is a girl in the family, the sister. He refuses to bring her in for testing because he says, nobody will marry her. And that's the issue of diagnosis. you know. I have said at least, okay, just let her know that this is what a normal period is. So she knows, what is normal, that she shouldn't be bruising, she shouldn't have nosebleeds and all that. So can you just tell her that? So it's a very touchy-feely, tough topic.
Yeah. And just as a follow-up question, you actually alluded to it already. In terms of diagnostics, so there have been many endeavors across certainly in North America, but all over the world to advocate for earlier diagnosis and so forth. Diagnosis has impact. It has impact on care, which is the positive thing. You hopefully get better care and affiliated with a specialized clinic and specialists. But it also has some negative effects, including feeling that we're sick or feeling that we have stigma. That's what I was getting to. But also insurance, reasons. So there's some negative fallout from it. And one of the things I was hoping you would answer to me is, and you've mentioned to me in the past about how diagnostics and diagnosis of a bleeding disorder in women affects everyday life for women in certain cultures.
Mm-hmm. So when you have a diagnosis of a bleeding disorder, then one has to be worried about stigmatization of the family, just not of the girl. The whole family gets stigmatized, and what happens when the girl is bleeding, the major thing people don't realize is that heavy bleeding leads to anemia, which has its own consequences. They're tired, and anemia is the most common blood disorder in developing countries. I can tell you that. The cause of anemia is usually, they think it is always nutritional, but may not be. And you have to think about other causes of anemia or other causes contributing to that anemia, which then leads to fatigue. And the woman is the caregiver of the family. She's the one who prepares the meals. She's the one who cleans the house. She's the one who goes to work. And she's the one who does just about everything. And when that workforce is gone, it's very hard for the family. And I find getting that message across that, hey, you need to be healthy for your family. You need to take care of yourself for your family. That message is actually taken, with a better this thing than saying, take this medicine. They will say, no way, I can't afford it. I don't want to take it. So it's a tough situation.
I'm getting many texts about, thanking you. I'll just, I need to say something here because I'm getting a slew of thank you for such an amazing presentation in the chat box here. So thank you. I actually have a question for you regarding tranexamic acid use. So we do know that, at least in the United States, I think it's called Listida, the longer-acting tranexamic acid, but you did not have tranexamic acid available for a very long time, actually, compared to Canada and Europe and other parts of the world. And my question to you is, now that it's readily available and your work internationally, how do you see tranexamic acid improving care for women all over the world? It's cheap. There's tons of experience with it. It can prevent postpartum hemorrhage in many instances, or at least treat it effectively. And my question to you is, how do you see that moving forward in its use in all these cultures and all these settings? It's not a hormone, so it obviates the need for that sort of discussion that's very delicate. It's not contraception. But it can be life-saving. So my question to you is, how do you see that moving forward in your advocacy efforts?
So I use it a lot. And I usually tell my patients in whom I use tranexamic acid the story of tranexamic acid. It is the story of a woman who was discriminated against. Dr. Okamoto, who died 2 years ago, worked with Dr. Nishida, was a scientist, and discovered tranexamic acid to prevent postpartum hemorrhage. That was the reason for it. So this was a specific drug for specific women and to prevent that. And she was not allowed to present her findings in research meetings, because they told her that, and she had to take her child to the meeting because there was no child care. And she was told that, this couldn't be. So there's Wikipedia has a very nice, if you put tranexamic acid, discoverer in origin has a wonderful story. So I tell my patients that here is a drug by a woman who cared about women, and it is to help. And it took us a long time to realize that. So I would definitely take it. And believe me, I went through that horrible thing where the pharmacy would not dispense it because of quote unquote thrombosis, and the insurance companies wanted me to give them results of 2 randomized clinical trials showing the effectiveness of tranexamic acid. I mean, that was the most ridiculous thing I'd ever heard. And it was just denying care for these women and girls, actually. So they said they would not give it because the girl didn't turn 18. So I'm like, okay, tell me the difference of a uterus of a 17-year-old and an 18-year-old. So you think there's a big difference that you can give tranexamic acid to an 18 and not to a 17, and they're both menstruating? So, I mean, it was like absolute crazy things. So I'm very glad, and it's cheap. And I have had it for my orthopedic surgery, my knee surgery, believe me, and it worked. And so I tell people I've had it for not related to bleeding or anything like that. It's a great drug. And we did studies at CDC where we showed that it was better, the P-back score went down more with tranexamic acid than
desmopressin.
With DDAVP.
Yeah.
Right. And so, and I usually use it. I heavily promote it for postpartum hemorrhage. I think the woman trial, showed us that it is effective. And I think there are currently trials going on in other pregnancy issues about the use of tranexamic acid. So yay for tranexamic acid. A lot of people use Amicar also. I know there are no studies for Amicar, but, short of doing anything using an antifibrinolytic, that's the bottom line.
Okay. Well, thank you very much. That wraps up our last talk of the day. And I want to thank you very much for being with us today and giving us a very insightful and, like I said, a special vision on women and bleeding disorders that I think many of us are not privy to. And so thanks for being our, I would say, our binoculars.
You're welcome, and thank you very much.
Thank you very much.
Take care. Bye-bye.